Well, thank you very much, Mr. Chairman and Ranking Member Murray, and thanks to the witnesses for being here today as well. I will join my colleagues on the minority side of the table here just to reiterate that while I think it is extremely important that we consider the user fee agreements, and I appreciate the chance to speak with all of you today, like many of my colleagues, I'm troubled that the committee has not been and is not addressing the issue that I hear most about from Granite Staters right now. I just came back from several days at home, and wherever I go, people want to understand what the implications of Trump Care are for them. And I hear from constituents all the time who, because of the Affordable Care Act, for the first time, got access to life-saving treatment. So while what you all are doing and what we're talking about here today is very important, without that underpinning of insurance coverage for many of my constituents, this is a little bit of an irrelevant conversation. So I hope that we will have a chance to convene hearings to the chairman's point that the United States Senate can do two things at once. We could convene some hearings on Trump Care before we have to vote on it. And I hope very much that we will do that, not only so we can make informed decisions, but so that all Americans can be part of an open and transparent process. Because the Trump Care bill as it now stands will hurt my constituents, it will hurt our country. And as the committee in this body with jurisdiction over many things in the Trump Care bill, that is the topic that I think we should be focused on today. With that being said, I do want to ask you all about a couple of things, and I'll start, Dr. Woodcock, with you. Too many Granite Staters and people across our country are struggling with an opioid addiction, and it's an epidemic in my state. It killed approximately 500 people in the little state of New Hampshire last year. I commend the FDA for putting out its opioid action plan last year, but I want to be very clear that there is still much more work that the FDA needs to do on this issue, and that it continue to play a role in confronting and beating this epidemic. For example, there are several FDA-approved opioids with so-called abuse-deterrent formulations on the market, and the user fees that we're talking about today help pay for review of these products. The FDA acknowledges abuse-deterrent does not mean abuse-proof, and has acknowledged that these products can still be easily abused by just swallowing a whole bunch of the abuse-deterrent drugs, for example. So, Dr. Woodcock, is it appropriate to call these opioids abuse-deterrent if they can still be easily abused?
They cannot be abused as easily in certain ways by snorting or by injecting, which are preferred by many addicts because they give you an immediate high.
Right.
All right. What we're trying to do is move up the scale and get more and more effective abuse deterrent technologies in place.
Yeah.
These are version 1.0. We acknowledge that, and they're still undergoing their evaluation to see, in fact, how effective they are.
Oh, just so I can understand, they are just as addictive, though.
They are opioids, and so what we are trying to do, in addition to introducing more treatments for opioid abuse, is to introduce pain treatments that don't have these liabilities.
Yeah.
And we have approved a number of drugs for specific conditions that now people are, like the neurologists, are moving away from opioids for peripheral neuropathy, for example.
Right, and I understand that, and that was actually going to be, so thank you for anticipating one of my questions. And I'm very glad you're doing that because, you know, I've been talking with my constituents about this, you know, both as governor and now as senator for some time, and I think that is very welcome news. I do want to get back to one issue, though, which is the use of the term abuse deterrent, because experts have done surveys now that show that 46% of primary care providers think that abuse deterrent products are less addictive than other opioids. And in light of this unsafe misconception, do you think calling these products abuse deterrent is misleading or causing providers to think that these products are less addictive?
It certainly seems as if more education is needed, and that is something that we are working on very hard. We are considering extending our educational program to over 100,000, I think, practitioners of various kinds, healthcare practitioners, have been educated under a current program, but we would like to extend that. Much of the abuse, though, of opioids is not these high-potency extended release, but is actually the kind of drug you get after you go for an in or out procedure, or you have your tooth extracted. And the question is, do you really need 60 tablets
Right.
with 3 refills?
Right.
And the healthcare system is actually awash, and actually people's medicine cabinets are full of these products that are not the high-tech products. They're the simple opioids. They're just as addictive.
Right, and I think, and my time has passed, but I think to that point, I would look forward to working with all of you on the FDA taking a greater educational role, because one of the issues we've had with providers, especially with licensing boards, is pushing them to change their prescribing guidelines so that somebody getting wisdom teeth extracted are leaving only with 1 or 2 days worth of prescriptions rather than a month or 2. So I'd look forward to continuing to work with all of you on that. Thank you.